Hello, good morning, everyone. My name is Miguel Angel Gonzalez Torres. I'm head of the psychiatry department here at the Basurtuko University Hospital. And it's a real pleasure for me to participate in the celebration of this centennial of the medical specialties training program. I think it's a privilege, not only a pleasure for me. So the topic I'm going to address is borderline personality disorder. And I've added a subtitle, Eyes Wide Shut. I think those of you who want to know why this strange subtitle will have to wait until the end of the presentation. Okay. So we are celebrating, as you already know, that this hospital has been training medical specialists since 1921. Again, it's a real privilege for us. So personality disorders, I think we can say that are the most neglected aspect of psychiatry, which in turn is the most neglected aspect of medicine. And this statement was made by Otto Kemper and Bob Michaels some years ago. They also said borderline patients have long been to psychiatry what psychiatry has been to medicine, a subject of public health significance that is under-recognized, under-treated, underfunded, and stigmatized by the larger discipline. What is personality? I think, as many of you probably will not be members of the psychiatric tribe, I think we should start defining these concepts. Personality means a set of emotional and behavioral traits that characterize a person in daily life and that are relatively stable and predictable. So personality, we can consider it as a style of attachment and a way of dealing with problems of different kinds. What is a personality disorder? We think personality disorder is an ongoing pattern of internal experience and behavior that departs markedly from the expectations of the subject's culture. This pattern is manifested in several areas. We can say cognition, affective regulation, interpersonal activities, of course, and impulses control. This pattern is inflexible and extends to a wide range of personal and social situations. One of the key things here is that diagnosis of a personality disorder always requires a longitudinal vision and a detailed life history. We cannot do a diagnosis of personality disorders in a single transversal interview. We need a longitudinal vision. We need to explore the past of the patient, their relationships, etc., etc. There are a lot of myths about personality disorders. Those myths are important because they can affect a lot the decisions and the attitudes of the clinicians towards personality disorders patients. One important myth is that these pathologies are hard, are difficult to diagnose, to measure, and to assess. That is simply not true. We have a lot of instruments developed by different teams and authors dedicated to diagnosis, to measurement, and the assessment of these pathologies. So not really hard to diagnose. Okay, difficult to treat. Many people think they are difficult to treat. Maybe, but in fact, we have a lot of psychotherapy models specifically developed to deal with these complex patients. Some psychotherapy models come from psychoanalytic proposals, others from cognitive behavioral proposals. We can see here at this slide four of the main psychotherapy models designed for these patients. Transference-focused psychotherapy, mentalization-based therapy, dialectic behavioral therapy, schema therapy, all of them have produced good evidence of efficacy in randomized clinical trials. Poor outcomes. There is an important attitude of pessimism regarding these pathologies and their treatment, but it is not supported by facts. Joel Paris performed a study with a follow-up of 15 years, finding at the end of the study that only 25% of that sample still fulfill a criteria of borderline personality disorder. And another leading figure in this field, Mary Zanarini from Harvard Hospital, McLean Hospital from Harvard University, performed a study following up patients during 6 years. And she found that almost close to 70% of them were in remission after that period. So not at all a poor outcome. And low prevalence. We go deeper into this later, but we can say right now that the prevalence is really high in some studies. For instance, the one made by Grant in 2008, they discovered nothing more and nothing less than 6% of the general population fulfilling criteria for BPD, borderline personality disorder. Maybe some of you know well the clinical picture of the borderline personality disorder, but not all of you. So I will emphasize some aspects of that clinical picture. The prominent symptoms are, on the one hand, affective instability, on the other hand, identity unstable and not integrated, impulsivity leading to substances use, problems in sexuality, self-harm, severe and chronic interpersonal problems, cognitive problems, a rate of suicide, completed suicide of 10%, a fact which is a huge, a very important fact. I mean, 10% of persons diagnosed with borderline personality disorder will die through suicide. And of course, 40% of patients with repeated suicide attempts in the emergency room do have a personality disorder. So the clinical picture is really severe and problematic. We also find a lot of comorbidity in these patients. We can find other personality disorders, substance use, eating disorders, affective disorders, and of course, anxiety disorders. Regarding the epidemiology of these pathologies, we can say that the prevalence in adult general population in Western countries is really high. We can find any PD in more than 12% of the general population. The prevalence is similar for the three clusters, A, B, and C, from 5.5 to 7.2% of the samples. And specifically borderline personality disorder, which is the disorder more studied and well known, it's more than 5%. Many personality disorder patients do not seek help in mental health. This is very important, but they visit primary care. So they are big users of health facilities, of health care. In the general population, not in the clinical samples, women and men have the same prevalence. In the clinical samples, the percentage of women is much higher than the percentage of men. In clinical samples, the BPD, the borderline personality disorder, has the highest prevalence. They can be even 10% of outpatients in mental health facilities, and up to 20% of inpatients in mental health inpatient units. We have here two big problems. One, low diagnosis, because often the patient is diagnosed with the clinical problem related to the admission, the reason for admission, And of course, the registration electronic systems in many health systems do not push us to register the diagnosis of personality disorder. So sometimes we don't know the patient has a PD, and sometimes we do not register that the patient has a PD. Another fact interesting to us is that we find lower rates in developing countries. We don't know really why is that, okay? Regarding the treatment, we have a lot of clinical guidelines, a lot of reviews, some of them very recent. One, for instance, prepared by Estorebo and colleagues, and published recently in the Cochrane database of systematic reviews. So all of this literature say the same thing, the same recommendations. One, psychopharmacology only has an auxiliary role addressing specific symptoms, and on the other hand, psychotherapy is the core intervention. These pathologies are a specific group in which we have as main indication, main therapeutic indication, a psychotherapy intervention. Which ones? Okay, there are several psychotherapy models which have proved important evidence of efficacy through randomized clinical trials. On the one hand, we have models derived from psychoanalysis. The two key models in this area are transference-focused psychotherapy, developed by the Otto Kemper group in Cornell University in New York, and the mentalization-based therapy, developed by Bateman and Fonagy in University College London. We have another cognitive model called cognitive therapy for BPD, not very well disseminated in Western Europe, and cognitive behavioral integrative treatment called dialectic behavioral therapy, probably the most disseminated psychotherapy model in borderline personality disorders. There are other besides DBT. Within the cognitive behavioral group, schema-focused, the famous STEPS model, etc. And finally, we have cognitive analytic therapy developed by Tony Ryle at the end of the 90s. So we have a lot of very well-proved psychotherapy models, okay? Some years ago, we here in Bilbao performed a study, a qualitative study, trying to know which one was the clinician's vision of actual treatment of personality disorders. And we found many clinicians share these ideas. Some time has passed since that study, but I am afraid the situation has not changed radically. It has changed in some level, thanks God, but the situation has not radically changed. Okay, clinicians view that there was not a specific attention to personality disorders in the health system. There were a clear lack of protocols, erratic psychopharmacology. The individual psychotherapy was scarce, irregular, and guided by a voluntarist attitude. Group psychotherapy, when you found that, was non-specific, not integrated in programs, and only in some centers. Clinicians felt overwhelmed by this situation, and there was a degree of therapeutic desperation, with a lot of pessimism regarding the final outcome of these patients. No? And very often we found the idea that there was an outpatient and inpatient revolving door. I mean, the patient came to the emergency room, maybe with a suicide attempt. The patient was admitted to the inpatient unit. He or she recovered in some level. They were discharged and they went to the outpatient unit, and again, a kind of repetition of the situation, no? Emergency room, inpatient unit, outpatient unit. So how are we really treating patients with a personality disorder right now? We could say it's a combination of creative psychopharmacology and management of admissions as usual approach. I say creative in two senses. On the one hand, creative because as there is no any single medication with an indication for treatment of personality disorder, clinicians were obliged to search for effects of some psychopharmacology medication, one or the other, trying to improve the situation of these patients. And creative in the other ironic sense of the term, no? Because sometimes this creative pharmacology in reality had to do with a therapeutic desperation and a kind of escape to a treatment you didn't know how to improve. And of course, the famous revolving door. So there is a very strong reality. Most patients with a personality disorder, and specifically with borderline personality disorder, do not receive adequate treatment. Causes for this. We can say, okay, we do not know. But is there no interest in personality disorder and its treatment? I think we cannot say that, because if you attend any congress, any psychiatry congress, when you find a presentation on personality disorders, usually the room is absolutely full, it's packed. So there is interest in the treatment and the knowledge of personality disorder. Is there an absence of trained professionals? I would doubt that, because probably we need more, but there are a good number of professionals with a good training of in psychotherapy models designed for PD treatment. The training is very difficult. Well, I wouldn't say it is very easy, but it's very not hard to acquire the knowledge needed to start treating patients with this model. It's not so difficult. Expensive training. Well, the problem here is that all health systems here and everywhere usually hand over psychopharmacology continuing education to industry and psychotherapy continuing education to outside institutions. So in my view, these health systems anywhere should take charge of the training in psychotherapy models dedicated to personality disorders treatment. So health systems do not finance continuing education of clinicians, at least in the really needed level. Okay, we cannot. There are usually two reasons stated here regarding this matter. Treatments are very intensive. They need high frequency of visits, and treatment duration is very long. Both statements are true in a way. You need a good enough frequency of visits, usually at least once a week, and the treatment duration is long. 6 to 12 months are not unusual in this field at all. So you need to dedicate a lot of attention to those patients, but you have to balance cost and benefit. Let's imagine a patient with a suicide attempt. He comes to the emergency room, then he has to be admitted at the internal care unit, then he goes to the internal medicine department, then he goes to psychiatry. So if we can reduce the number of patients attending with a suicide attempt, for instance, to the emergency room, we will have a lot of savings, economic savings, besides the benefit, for the real benefit for the patient with the treatment specifically designed for him or her. No? And of course, in the public health system, we must pay attention to group therapies. I mean, group therapies are a high quality psychotherapeutic indication, psychotherapeutic intervention that can easily be applied to a public health system. In fact, some of the psychotherapy models I've mentioned before are developed through group interventions. I don't know, MBT, for instance, or of course, DBT. One of its components is group intervention. So I also ask myself, is it true we cannot fit those patients in our schedules? Is it true that? Allow me to doubt that. I know that in some facilities, we can really fit many of these patients in our schedules, okay? We do not want, for some obscure reason, we don't like to treat those patients. We expel those patients from our offices and our inpatient units. Let's reflect a little bit on that. I remember many years ago, I was in the emergency room and a patient came through the door with two policemen on each side, and he shouted to me, "Hey, doctor, here I am again." A substance abuse patient who had come many times to the emergency room, and he knew me because of that. And when I was waiting for the patient to come through the reception area, etc., I had the opportunity to listen to some colleagues from other specialty talking to each other close to me. They didn't know I was listening to them, but they were doing all kind of hostile comments regarding the patients in general, like him, substance abusers, personality disorder patients, etc., etc. And I was astonished of the hostility awakened by the patient in these colleagues. Later, I knew that these colleagues had never treated these patients. So it was a kind of general reaction, not specifically related to this specific patient. How come? What happened there? So up to now, we know something. On the one hand, personality disorder and specifically borderline personality disorder show a high clinical severity, a high prevalence, also in the general population and in the clinical population. We have well-known effective treatments, but they are not used, or at least they are not used with the frequency and intensity we should. And most patients with personality disorder do not receive adequate treatment. The only consolation here, and I know it's a poor consolation, is that this happens anywhere. I mean, this situation happens here in the Basque Country, in the rest of Spain, in England, or United States, or wherever. I think this happens almost everywhere. But the key problem here is that there is no strategy to address this situation. There is not a clear strategy to address this situation. So, in my view, we should make a reflection I want to share with you today. What a personality disorder patient is awakening in us? In a descriptive level, very often they provoke in us irritation, envy, rejection, anger, fear, attraction, sometimes fatigue, a lot of negative reactions in front of them. So it's easy to favor the patient's dropout from treatment. Of course, we don't want the patient to drop out from treatment, but unconsciously we can push him or her to do precisely that, related to the negative reactions he arises in us, okay? Besides that, it's easy to punish him or her for his or her aggressions, devaluation, or his attitude towards the treatment and towards us. And of course, it's easy to transgress limits with them in a way, directly or indirectly, to facilitate his or her dropout from treatment. if we try to go to a deeper level, we can experience an activation in the treatment of object configurations linked to bonds with affectively significant figures. In other more simple terms, the patient repeats with us problematic relationships he or she has experienced with other people in their lives. No? In these object configurations, we can distinguish an object representation, a self-representation, and an affect linking both representations. The borderline patient projects split visions, often very negative, onto the therapist. The borderline personality disorder patient very often consider his therapist as being a person full of negative traits, sometimes extremely positive. Through this splitting mechanism he is using every time. And a therapist often identifies with this object representation and makes it his own. You can, let's say the patient has a very negative view of you, and then you can identify with this negative view. So in fact, you end up treating the patient very negatively. The therapist-patient couple becomes just another couple in the patient's life, subject to the ups and downs of representations of object and self. So we develop with the patient a relationship similar to other, sometimes very bad, the patient has experienced in his or her life. The result in the therapist is confusion, anguish, intense and difficult to manage emotions. No? Those are difficult emotional problems with which the therapist has to deal. No? And this negative combination contrasts with this longed-for relationship we all would like to experience. No? We all clinicians would like to be a benevolent, wise therapist gratified by patients' improvement and appreciation. This is the ideal situation we all long for. But sometimes this is not what we find. Let's talk a little bit about the stigma. With this term, we mean a negative view of mental illness and the sick persons, generating social rejection and discrimination. Violence, danger, unpredictability, immorality, all those traits are related in society's fantasies about mental illness. No? We fear those personalities or the patients will give us violence, danger, etc., etc. Stigma, of course, is common to a multitude of situations that the population rejects. No? Being a foreigner, having another skin color, another religion, some illnesses, using a different language, etc., etc. In fact, any differentiating characteristic can serve as a basis for a stigma. Fear of the different is the key issue here, of the unknown as the origin of a stigma. This is a universal phenomenon, but in mental illness, stigma acts as a second disease, which adds to the first disease the patient has. The patient has personality disorder, plus he or she suffers a stigma for having this disorder, okay? I would like to share with you the hypothesis that we really do not want to treat those patients. This is a very important assertion, and I am convinced of it. We do not want, really. The patients, and especially the severe patients, receive the deposition of aspects rejected in us, aspects that are especially related to sexuality and aggression, because these patients represent all that we deny in us. No? Unpredictability, violence, self-aggression, impulse discontrol, chaotic and promiscuous sexuality, affective dysregulation. all these aspects, we don't want them in us. And being afraid of those aspects, we tend to project them, to deposit them on the patients we are treating. So they become people we should reject. No? In my view, the surprisingly low level of care for BPD, taking into account their severity, their frequency, and the fact that effective and feasible treatments are available, could represent a global acting out of our community, I mean the mental health community, attacking them with our inattention. What to do? Well, in the first place, we should observe, we should pay attention to this and try to examine what is happening with these patients in our respective facilities and institutions, and try to understand how we are treating these people, what are the results, what are the reactions to our treatments, etc. So first, observe. Then making one step back. No? We should observe and think, not acting out immediately. We have to examine all these different aspects, conveying on the real treatment we provide to these patients. What is our role? What's the role we are playing? Are we trying to understand the patients and giving them the best treatment available? Are we depriving them of this? Should we change our way of attending these patients? No? Of course, we should understand the role assignment is on the table, no? And step out of acted roles without expressing them. Due to these negative emotions provoked in us by patients, we should observe, do one step back and try to extricate ourselves from these actor roles, not identifying with negative aspects deposited by the patients on us. And finally, we must treat. The patients need it, their families need it, society needs it, and of course, healthcare needs it. And this is the last slide of the presentation. Why I was using this peculiar subtitle, Eyes Wide Shut. You probably remember the movie directed by Stanley Kubrick. I think it was the last one he made. And in this beautiful movie, we have two levels. You could see two levels in society. A surface level where rationality and educated relations and culture, etc., was on view, and below that surface there were another deeper layer of sex and aggression. Many people didn't want to take a look to that deeper level, but we should take a look to that, and we should try to understand what is happening below this surface of irrational attitudes and understanding. So this is all. Thanks a lot for your attention. It's been a pleasure to participate in the centennial celebration. Thank you.